Hi, this is Dr. John Martin, Chief Medical Officer of Butterfly Network, and I welcome you again today to another fireside chat with one of the country's leading experts at point-of-care ultrasound and an emergency medicine doctor extraordinaire. I'd like to welcome John Kendall to our fireside chat. Hi, John.
Hey, John, thanks for that introduction. I'm not sure everybody would agree with you, but I appreciate that.
Oh, there are legions of admirers, John, across the country. For the rest of the audience that may not know you, why don't you share with us your background a little bit? Tell us about yourself, your education, and where you practice medicine today.
So, yeah, I trained back in the days when there really wasn't point of care ultrasound. So, back in the early 90s at LA County, and that's where I started the program and then came to Denver Health, and that's where I practice now. And I've actually been there my entire career. Been really fortunate to start the fellowship, be involved in the School of Medicine, teaching ultrasound, and then all of the clinical implementation at Denver Health. So I've been pretty much ultrasound my whole career, and most of it has been in Colorado.
How many offspring doctors do you have around the country, if you will, that are disciples? Because I seem to keep running into, oh, John Kendall, yes,
Yeah,
he taught me how to do ultrasound.
yeah.
You've never stood back and counted how many there actually are?
There are a few, quite a few. One of my favorite events is the ultrasound fellowship alumni get together at ASAP every year, and we every year have a big group of them come, and it's up to over 30 people that'll come, and everybody is doing all their things all over the country, all over the world, really. And that's one of my favorite times of the year is to get together with the old fellows.
So you were early in this point of care ultrasound world, if you will. I mean, going all the way back to LA County, and I remember interviewing at LA County actually for a
Yeah,
residency program, quite a wild place, in the
right.
same kind of thing as Charity, if you will, and Parkland and Ben Taub, all of the same kind of ilk
Right.
institutions. What got you started in point of care ultrasound? What drew you to that? Because it was not commonplace when you first got into it.
Right. Yeah, no, it really was almost a necessity. There were so many patients that came into the county hospitals, and I'd add on Highland and Bellevue, and at that time, King County, there was a number of them that were similar, and we just had too many patients that came in with complaints that ultrasound could potentially answer that question, like gallbladder disease or patients that came in with trauma. And it was really an access and a quality of care related issue that we saw how ultrasound could be helpful, but we saw other people doing it. And so we decided that there would be some things that we thought were well within our scope of care that we could learn how to do, and we started doing them. And sure enough, we had great outcomes. Things like patients doing better survival, decreased length of stay, better outcomes when it came to procedures. And so it was really almost out of necessity that we had to do it based on the volume of patients, and we picked things that we thought could really make a big impact. It was fun. I mean, it was, back then you didn't really know. Nobody told you what the applications were going to be. You just had to kind of experiment in a way. And it was a great experience. It was
So
a lot
what
of
year
fun.
was that, John? When you look back at your, what the formative years were, which years?
So started at county in '92, and got the machine in '93, kind of '94ish, and didn't have anybody to teach me how to use it. There were no fellowships back then, so I just scanned thousands and thousands of patients, and would just do scanning shifts and scan and scan and scan. And actually, one of my very first publications was incidental findings that I detected during those scans, because I started picking up things that otherwise wouldn't have been detected. Masses, polycystic kidney disease, all sorts of other things. And I just realized how much opportunity there was if we did scan patients, not only for indicated things, but sometimes just in the course of routine scanning.
So it's kind of a two-edged sword, though, right? All those people that look at people scanning and say, "Oh, those incidental findings are going to lead to bad things." That's been a topic of some controversy over the years, hasn't it?
Yeah, I think it is. It definitely is. And it depends on what you're scanning. Like if you're scanning thyroids, then clearly you're going to find a lot of thyroid masses that many of them may not end up being anything. The things that I was finding were at least as we looked at them later on, were significant. They weren't insignificant things. The funny thing, and actually it's not funny, I think it's actually pretty serious, is that almost all of the malpractice cases that have come out of emergency ultrasound have not been when somebody's done a study, either misdiagnosed something or found pathology that came up incidentally. It's been in those instances where physicians didn't use ultrasound and it was a potentially indicated situation. But back in those days, we were very concerned about missing things or not identifying things correctly. And so if we did find an incidental finding, it was something that we followed up. We'd consult with radiology and get further imaging. It didn't happen all the time, but clearly it did happen other times.
Well, I emphasize this, and it may seem kind of silly this many years back going back, is because I see that transition moving toward primary care, toward these other specialties that are trying to adopt ultrasound now. And I think there's a lot to be learned from guys like you that went through that period, what you should be afraid of, what you shouldn't be afraid of. And maybe the most important thing is the way you learn is you just got to scan and scan and scan. And then I think that take home message is we have this tremendous safety net. And that is, we can always send the patient, which we would do anyway, under normal circumstances, to a highly trained sonographer, radiologist. There's this great backstop that we have for part of the educational process. Do you see parallels to what you went through and your colleagues in emergency medicine and how that can be transferred, if you will, to primary care, which I think is the place most ripe to learn from what you've learned?
Right. Absolutely, John. I see almost identical paths, but taken a little bit differently. Again, we were pretty scared. We were not scared in a like we were fearful, but we were very cautious of what we were doing and making sure that we weren't doing things to harm patients by in going into the areas, the applications that we were going into. And we were very deliberate about the applications that we chose. We wanted them to be very focused, one or two findings, impacted clinical decision making, and something that could be fairly easily learned and done quickly. And one of the things that I see and that concerns me is I don't know that there's a healthy dose of fear in some of these other specialties and other groups that are coming on board, that they don't maybe appreciate the fact that it is a very powerful technology, but there are limits to it. And you need to be very proficient at the scans, knowing what normals are, but then also have very defined reasons for going in to do the studies and limiting those initially. The novice, the folks who are just coming on board should probably be very specific about the things that they choose to do and not some of the more advanced applications.
Yeah, I kind of use that mindset. And there's a lot of different ways to talk about this, but I call it land and expand. You land on something that's pretty straightforward and simple to do. And there are some, and we'll talk about them in a moment. And then as you gain confidence in those, you step on. We often think about education, and as you learned in your fellowship, you train your residents throughout the whole year to be really good at a broad range of things. The adoption into healthcare now is a little bit more focused, modular, very narrow, binary decisions. And I think the new people coming on board that don't have the benefit of a fellowship should think about it that way. Land on something simple, then expand your knowledge base over time. I think that's a logical approach, don't you think?
Yeah, absolutely. And then because not everybody's going to be the same. Certain people are going to be able to expand quicker than others. But others, they may need to stay in that landing area for quite a while and really become proficient at it before they expand. And I think that's a fantastic approach, as opposed to being too widespread and being poor at everything. Really identify what you're good at and what your learning curve is, and then expand as you go from there.
Well, speaking of something that you can land on, that's practical today, that's in everybody's attention, and is a relatively straightforward scan to do, let's talk a little bit about lung scans and your exposure to this COVID pandemic. What has your experience been like at Denver? Volume of patients that you've seen, maybe some adjustments that you've made, and maybe how you're using ultrasound in this group of patients.
Yeah, we clearly have not been hit as hard as some of the other places in the country, but we are a safety net hospital, and Denver Health is a very busy hospital where a lot of folks who are underserved come for their care. And so our volumes of COVID patients have been reasonable. Again, it hasn't been to the extent of what other places have, but we did set up COVID areas or respiratory zones within the department, brought ultrasound into that. And one of the very first things we found was that to decon one of our cart-based system took 6 minutes and 6 wipes. And that's just not practical for us with the volume of studies that we were doing. I mean, everybody was getting a lung ultrasound. And so we deployed hand carried devices, deployed a butterfly to to those areas, put it on an iPad mini, and it became the COVID ultrasound machine and had a very specific place that we uploaded those images so we could review and get a sense of what we were finding and how those results were influencing care. We also had another area though, which was it's an urgent care area, but they still see kind of low risk COVID patients, and they also had a respiratory zone. And it's staffed with physicians, but also advanced care providers. And when we started looking at their use of imaging, they were ordering a lot of chest x-rays on these relatively low risk patients. And so we had gained some experience with ultrasound in the adult area and the pediatric area, found that it could be useful and also useful to identify low risk patients. And so that's when we stood up the tele-ultrasound program in the adult urgent care area, because they had no exposure, no previous experience with ultrasound. And that was a pretty remarkable experience to stand up an ultrasound program in a place that had never used it before and literally went from 0 to 100 with what they were doing with ultrasound within a matter of a day.
So you had two healthcare professionals, both on both ends, but just varied levels of experience using ultrasound, and you leveled much like, I think the analogy I think of is when you're in the operating room and you're operating with an intern or a second year resident and you're an attending. You're both competent people, you're healthcare providers, just one has a little bit more experience than others. So how did you find teleguidance? Did it accelerate learning? Did it provide insight into those patients? How did it work for you? How does the system work?
Yeah, it actually, it literally did take a program from 0 to going just by turning on a switch. And normally when we think about bringing on a new group of providers with ultrasound, we think of all of the education and experience they have to have before they can start doing it. We were able to just implement it literally right away.
So it accelerated learning and made people better scanners quickly in your setting?
Yeah, I definitely accelerated the ability to utilize that information. And, whether we didn't really measure learning because we were guiding them both in terms of acquisition and interpretation the whole time. So the remote collaborators were. But our primary objective was to decrease chest x-rays as a primary. Our secondary goal was to decrease nosocomial spread or potential nosocomial spread from these imaging or portable devices like the x-ray machine, and then also decrease exposure, potential exposure from the x-ray techs, and then decrease time. And when we looked at those things, it was remarkable the difference that it made in patient care, where they were getting x-rays on almost all of those patients, and we were able to decrease x-ray utilization and put it, basically have it, or half of the amount previously was being done after we implemented the ultrasound program.
So you've done a really good job of publishing your results. I assume you did this as a research study, as you typically do, I assume, which is terrific, because I think that kind of information is incredibly helpful for us. And so I suspect you're going to look to publish this data, which would be helpful for people.
Yeah. I mean, I don't want to tell you all the results, but yeah, we will
Well,
absolutely.
listen, this is like the news, man. I got to get the sneak peek at the results. I want the scoop here. I want to
Yeah,
scoop the other stations.
I'm giving you all the scoop. No, I absolutely. I mean, I think anything we do like this should be done in a way that that it's scientific and that it can be scholarship and research, and this is no exception. I think of this as an initial opportunity to look at how teleguidance can be stood up in an area where ultrasound has not been previously. And when I think of the future, I think of this is how it can be expanded, how we can go beyond with ultrasound in a way that we couldn't previously do it, and have oversight both with acquisition as well as interpretation that we've never thought about previously.
As you look at how a point of care ultrasound has evolved for you and your educational program, where do you see teleguidance fitting into your fellowship now? So you have let's assume when the dust clears from COVID, and we know we're not there yet. There's a lot of people still passing away tragically, but we do have to look past COVID. And I think thinking about that as we start to calm the waters, what are the important lessons you learned through COVID with and without teleguidance? How do you see it changing the way you guys practice in the emergency room? And where does lung ultrasound go from here? We'll look at those three questions.
Yeah, I can see a very clear path for teleguidance in hospitals, emergency departments, even inpatient services, where they don't have someone who can guide them and help them with either QA or even image acquisition and interpretation. And you can have a consulting service. Basically, you could stand up an ultrasound program in a place that previously didn't have it, who may have wanted to hire somebody who's ultrasound trained, but that person was not going to get there for one reason or another. And so I do think it's an opportunity for more remote hospitals or hospitals that haven't previously had ultrasound to have those programs. And I can imagine a way that you would set up a system where it could just kind of spread from there. In terms of fellowship programs, clearly they need to be very facile in doing teleguidance. I think teleguidance in medical care is something that we have to be prepared for as well. But teleultrasound is something that I don't think it takes that much skill, but it is something that we need to be educating our fellows to be able to do so that they can be part of this as it moves forward. In terms of where we go, I think there's other opportunities. You can imagine the military as well. What would have happened on the Roosevelt if they would have had access to ultrasound and could have been screening some of the folks that were on that ship to decide who was sick versus who's not sick. I mean, I think there's a lot of other out of hospital environments where you can imagine teleultrasound being very useful and impactful, whether it be in austere settings, global settings, or military settings as well. Lung ultrasound is, it will always, I think, evolve lung ultrasound to understand a little bit more. I'm always learning about lung ultrasound. I feel like it's something I don't know that I have an actual idea of how it's going to be used. For instance, I don't know right now what's most predictive when I do a lung ultrasound on prognosis in a patient who comes in with COVID. Is it subpleural consolidation, or is it something related to B lines, or are there other findings? I don't know. And I think those are some of the things that we'll have to know as we move forward. But I also think there are ways to bring deep learning and other ways to identify those pathologic findings much easier, so that there's less subjective component to lung ultrasound, which I think there is some of that right now. And so you can bring in deep learning to identify findings with more specificity than we potentially are able to do right now.
Yeah, I think that's a pretty exciting field. And I think, unfortunately, in the midst of all this, it's hard to do research when you're getting swamped with these patients. But I think the goal afterwards is, how do we consolidate our data and throw that at the machine learning scientists to see what they come up with? We subjectively look at, quote, and I'll put it in quotes now, I've learned, the thickened pleura, knowing that it's not really thickened. I get in trouble for saying that. But is there a way to do other than you experienced guys look at this and you say, that's bigger than it should be, but we don't have real objective criteria, and maybe getting some of that would be helpful, or that really is a skip lesion. It's not your imagination as you're going over it. So that would be helpful. I think things like that, could be helpful in the future. As you look at expanding from lung ultrasound to other areas. Have you used a lot of ultrasound looking at cardiac issues with COVID? Have you seen that myocarditis, if you will, that cardiac decompensation that some have talked about, the Seattle group, for instance?
Yeah, we have. And, I probably can't talk about them in detail, but we've had cases that have had a very similar progression to what other people have described, where they came in with shortness of breath and then prior to intubation, cardiovascular collapse, and then having to resuscitate after that. We included a cardiac assessment in our COVID assessment. So we didn't just do lung. We actually have cardiac with long axis parasternal and an apical to try to get a sense of, can we predict who's going to do poorly? We haven't had enough cases to be able to really define that, but I do think once we call all of our data together, I do think we'll have hopefully some answers about that, and maybe it will help us choose which induction agent we use. So propofol was used in some of those studies where they had rapid decompensation. Well, maybe we'd use etomidate or ketamine instead, and those are the kind of things that when the dust clears, I think we'll be able to have a better clarity on is how valuable is an ultrasound in the assessment of COVID patient, and then is there value in doing it right before somebody's induced to potentially change the med that you may use as your induction agent.
So when you think about COVID, one of the things we talk a lot about are B-lines because they're there. Prior to this, did you do a lot of ultrasound for congestive heart failure and use B-lines as your measure? And how did you compare that to, say, BNP or some of the other tools that are typically talked about?
Yeah, so clearly I've done quite a bit of it and looked at a lot of B-lines and used it more in the undifferentiated shortness of breath, so COPD versus CHF, and trying to make that determination of initial treatment for somebody. We had not used it as in combination with or in correlation to BNP, and have not used it for progression of patients that have congestive heart failure yet. That's just not something that we have in our observation area that we'd be able to manage people that way, but I can see potential value in that, that especially instead of other markers that may be less reliable.
It's interesting, and I think it was Vicky Noble, and I may get this wrong, you would know better than I do, that actually looked at B-lines in dialysis patients that had B-lines, and literally you could watch them be dialyzed away. That's how quickly that they go away.
Right.
You can certainly see an opportunity where that might be helpful.
Absolutely. And that's the way I would envision it in the moderate, low risk congestive heart failure exacerbation, put them in an observation area, and then measure their B-lines and their symptoms, and then discharge potentially based on resolution or improvement of their B-lines and their symptoms. But you can also imagine home care similarly. That there's a lot of patients that come into the emergency department just because for congestive heart failure, it's just because that's the only option they have. But you can also imagine a scenario where we could monitor them at home with ultrasound and have a very objective measure of their progression, regression, and know whether they need to come in, as opposed to just basing it on symptoms, which is what we do right now.
And that's an area of study that we're working really hard on, and I think that would make a big difference. We know what a great burden they are to the healthcare system coming in and how expensive they are. The flip side is they don't want to come see us anymore. Then the system wants to see them. And so I think if we can find a better way, we talk so much about reducing admissions, reducing ER visits. What patients want are doctor-free days. They want us out of their life, not in their life. So I think this could make a difference. If you had to walk away from this COVID situation, is there a lesson learned for you, something that you learned unexpectedly from all of this that you didn't expect coming into it? Because you're one of the most experienced emergency physicians around the country. Yeah. What surprised you about this, and what did you learn?
It surprised me how sick some of the patients were. I had heard how sick they were. I could imagine how sick they were, but to see young patients who are previously healthy, not able to breathe was pretty remarkable and impactful to me. I also think the way that how careful you had to be during a shift to make sure you weren't exposed was mentally and is mentally exhausting. Literally, the point that you go onto a shift to the point that you go off, your mind is always on. And I'd not had an experience like that. I've had shifts that are busy. Clearly, I've had shifts that are busy, but not where it was uninterrupted concentration to make sure that I wasn't potentially exposed. But the other thing that has been, to me, more than just a silver lining in this is how people have come together to help out. And whether it's been within the medical community, within a hospital, outside a hospital, communities, private sector, I mean, it really has been coming together to address something that none of us have ever experienced before. And so I hope coming out of that, that there'll continue to be things like that, where we will work collaboratively across specialties, across hospitals, across countries, to deal with some of the issues that we deal with on sometimes a daily basis.
I think that's such an important message. In healthcare, we take a long time to learn new things. Listen, you started with ultrasound 20 years before it really made it into this kind of the mainstream,
Yeah.
if you will. And it still hasn't gotten all the way across, despite the fact, I mean, we know ultrasound's more sensitive than a chest x-ray. We know that already. We've known it for a long time. Yet chest x-ray still exists because we're slow to change. Maybe this will change that. Maybe there's an acceleration, if you will, and telemedicine, teleguidance, and the future of healthcare working together will be one of those nice byproducts of all of this. Well, we've really enjoyed talking to you today. You're a very special physician. We're very lucky at Butterfly to work with you on a consistent basis. The research that you do is really advancing the knowledge of everyone across the world. So please keep doing it. Please keep yourself safe. And we look forward to spending more time with John Kendall in the future.
Great. Thanks, John. Appreciate it. Have a great day.
You too.